Hi, I'm Dr. Michael Cohen, and I'm the Director of Gastrointestinal Endoscopy at Physicians Regional Medical Center in beautiful Naples, Florida. Welcome to part one in our three-part series on the use of the Blakemore tube. This is designed for endoscopy nurses and techs who work in gastrointestinal endoscopy. Now, we watch videos all the time, TikTok, YouTube, Instagram. But how often can we say that we're going to watch a video that's going to actually help us save someone's life? Well, I can pretty much promise you that if you stay in gastroenterology long enough, you're going to encounter a situation where the use of a Blakemore tube is going to be the difference between life and death. And I can promise you that if you watch this three-part series, you're going to be ready when it's time for you to participate in the use of the Blakemore tube and saving someone's life. The topics that we're going to cover in this series include: when do we use the Blakemore tube? What situations are proper for the use of the Blakemore tube? Second of all, why do I need to know this? As an endoscopy nurse or tech, why is it important for me to know this information? What does the Blakemore tube look like? And what accessories do I need to use in order to use it? And finally, how do I actually use the tube? Well, here's an endoscopic view of esophageal varices. I'm sure something that you've seen before in the endoscopy lab. And the problem with esophageal varices is that they can bleed. And when they do, it's usually an acute medical emergency. So what do we do when there's an acute variceal bleed? Normally, the technique to get that bleeding stopped is band ligation of the varices. You're probably all familiar with banding varices, but just in case, we use a little cylindrical device on the tip of the scope. It looks like a little cylinder, and we suction the bleeding varix into the tip of the cylinder, and the cylinder is wrapped in these small rubber bands that we deploy onto the varix to stop the bleeding. As you can see on the right side, you can see where a band has been deployed on the varix, and it stopped the bleeding. It turns out that band ligation for varices that are bleeding is highly effective. About 90% of the time, we're able to control an acute variceal bleed with band ligation. But what about the other 10%? When we can't stop acute variceal bleeding with endoscopic means, it's a true medical emergency. And normally what we do in that situation is we refer the patient to our interventional radiologist who can perform a TIPS procedure, which is usually highly successful in stopping the bleeding. The problem is there's usually a lag period between the time that the patient leaves the endoscopy lab and the time that the patient can go down for the TIPS procedure in interventional radiology. The radiologist may need to be called in from outside of the hospital. They may be in the hospital, but doing another emergency procedure. They may have to assemble their staff and their equipment. So there's usually some delay before the TIPS procedure can be performed. So our job is to try to keep that patient alive until they can get down to the interventional radiology lab and have the TIPS procedure. And that's where the Blakemore tube comes in. And when it's time to put it in, I want you to be ready. You may be asking, why is it that I should know about this as a nurse or a tech? What about the ICU staff? Doesn't the ICU physician or ICU nursing staff know how to do this? Well, usually not. They usually don't have experience with putting in a Blakemore tube, and they usually defer to the gastroenterology team to do so. What about the ER staff? They deal with emergencies and bleeding all the time. Well, again, same thing. It's pretty rare that an ER physician or nursing staff is going to have the background to know how to put one of these Blakemore tubes in. How about the GI physician on call? Surely they know how to put the Blakemore tube in. Well, it may be that the doctor on duty does not have a lot of experience with the Blakemore tube, or maybe even none at all. So you may be the person as the GI nurse or tech with the most knowledge on how to perform this life-saving procedure. So I want you to be ready when the time comes. How do you do that when you only put in the Blakemore tube very rarely, maybe even once every couple of years? Well, just like the flight attendants on an airplane rarely have to perform an actual emergency evacuation, by knowledge and by drilling in the procedure, when the time comes, they're ready. So when the time comes for us to put in the Blakemore tube, I want you to be ready. Thank you very much for watching. And I'm going to ask you a big favor, and that is to subscribe to this YouTube channel so we can keep these instructional videos coming. I'll see you in part 2.